Welcome. So today let's talk about ventilation versus respiration. And this gets into a question of, what are we doing? So what are we doing here with a non-rebreather mask? What are we doing here with a BVM, bag valve mask um, ventilation? What are we doing here with a CPAP machine, CPAP setup? And oh lordy, what are we doing here with our intubated patient on a transport ventilator? Well, first let's talk about ventilation. So we're talking about ventilation or respiration. We're going to talk about ventilation first, and let's just remember that ventilation is just the movement of gases, just a physical movement of gases in and out of our system. This is a mechanical process. So as we inhale, as we inspire, our thoracic cavity is going to expand, our diaphragm is going to contract, create negative pressure within our lungs. That's going to actively pull in air. So remember, ventilation is just a physical movement. So we're going to uh, pull in air, actively pull in air. As we expire, our diaphragm is going to relax. Everything is going to relax. Our intercostal muscles are going to relax. And we're going to exhale, and that's a passive process. So remember that inspiration is an active process. It needs all of our muscles to contract and move. Our expiratory cycle is going to be a passive process where all of our muscles relax, and the negative space inside our lungs, that negative pressure, now equalizes, and we can passively exhale. Now we can't talk about inspiration, expiration without talking about fluid dynamics. There's a whole law uh, governing the flow of air, and why we talk about fluid dynamics when we're talking about airflow. Well, we usually talk about this in terms of IV catheters. We know that if we go from a 22 gauge catheter to a 14 gauge catheter, we can increase the flow of fluid through that catheter. Well, the same law applies to our airways. So our flow diameter, 1 over the radius of that tube, and that tube being our airway, our airways, 1 over the radius to the fourth power. So as we increase the radius of that tube, and again, we usually talk about that in terms of IV catheters, but here we're talking about that in terms of airways, whether they be big or small. As we increase that radius, we have a fourfold effect on the flow. So think about going from that 22 gauge to that 14 gauge. Well, the same thing with our airways. If we go from a small airway to a big airway, we can move a lot more air. So let's talk about the flow of that air, and a couple flows that we are interested in, that we need to be cognizant of when we're talking about, again, this is ventilation, the movement of air, is we've got two of them, laminar flow and turbulent flow. When dealing with our patient, especially respiratory patients, we've got laminar flow, we've got turbulent flow. Laminar flow, we always want to increase laminar flow for our patients. Laminar flow is, again, we're going into fluid dynamics. Laminar is just a straight line, straight flow. So we definitely want our air going straight down our airways, no impediments. It goes from upper airway to lower airways in a straight line. So when dealing with our patients, be they respiratory or not, but especially our respiratory patients, think of an asthma patient. With our asthma patients, we definitely want to increase laminar flow. So when we are oxygenating and providing treatments, we can get the air going from the upper airway to the lower airways in a straight line. Conversely, with these patients, we want to decrease turbulent flow. So our turbulent flow, think that or think of that as the antithesis of laminar flow. Turbulent flow is not a straight line. It goes, bunka, 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 bunka down the airway. It is all over the place. This is the riptide of our airways. So air is not getting from the upper airway to the lower airways in a straight line in an efficient manner. It's going all around the place, and it just, it isn't getting there, is the end result of all of this. So with our asthma patients, we want to increase laminar flow and we want to decrease turbulent flow. But turbulent flow doesn't just happen, right? So if we look back, we've got our airways there at the top of the bottom. Let's say our walls of our airway, and they look the same. We've got our laminar flow or our straight line. We've got a turbulent flow, but our airways look the same. But that just doesn't happen on its own. Typically, we've got airway constriction causing turbulent flow. So we start with this laminar flow, these straight lines. We hit some sort of airway constriction, and all that air coming in hits this impediment and starts bouncing all over the place. So now we have this turbulent flow, and the air getting through this constriction isn't fully getting to my lower airways. Now, in treating these patients, we can decrease turbulence or turbulent flow. So continuing on with our asthma patient, how do we decrease airway turbulence? We've got a number of measures, a number of treatments we can provide. The first of which would be beta agonists. We've got albuterol, we've got Xopenex, we've got formoterol that we can give. All these beta agonists that will bronchodilate, reduce airway constriction, and decrease turbulence. We've got anticholinergics. The foremost is ipratropium or Atrovent, which will clear up airway mucus and secretions. Again, the bronchodilator in a way and decreasing turbulent flow. And we've got steroids, which is a little bit of a longer term treatment with maybe solumedrol or dexamethasone. And with these steroids, again, decrease inflammation, decrease that airway constriction, and decrease turbulent flow. So remember, for these patients, we want to increase laminar flow and decrease turbulent flow. We can also consider Heliox, and Heliox, not too many EMS agencies provide this. You see this more commonly in hospitals, especially pediatric units, but Heliox is a mixture of oxygen and helium, up to 80% helium. So helium has a super low specific gravity, really, really lightweight. So what it does is lower airway resistance. We're still delivering oxygen, so we can play with the mixture there. If we want an FiO2 of 20%, we can go ahead and provide that. If we want an FiO2 of 50%, we can go ahead and provide that as well. But with the helium added to it, we are lowering our airway resistance, we are increasing laminar flow, and we are decreasing turbulent flow. Well, what if I put my asthma patient, let's say, on some high flow oxygen, and I want to fix my asthma patient with high flow oxygen? Is that going to reduce turbulence? Is that going to reduce turbulent flow? Well, no. That is not going to do anything to the airway. So we can pour in as much oxygen as we want. That is not going to reduce turbulence. That is not going to increase laminar flow at all. So we need to be cognizant of both the oxygen that we're giving, and we need to be aware of the size of the tube that we're dealing with, that airway. We need to be aware of the laminar flow and turbulent flow. Well, what about CPAP? I've got an asthma patient. Maybe I put him on CPAP. Will CPAP work? Will CPAP decrease turbulent flow and help increase laminar flow? Kind of. Not, but not really, right? We're just forcing air now. So we've gone from a high flow oxygen to a forced high flow oxygen. So we're not really fixing the tube issue. We're not really fixing the turbulent issue. We're not really fixing the laminar issue. It will help recruit alveoli down in the lower airways, but we're not really fixing the issue at hand. Now let's talk about respiration. We just went over ventilation, which is a physical movement of gases. Respiration, on the other hand, is going to be an exchange of gases at that cellular level. Respiration works with ventilation because with ventilation I've got gas coming in. Well, we need to do something with that gas, with those gases. I've got gas going out. Well, we need to do something with those gases. So I've got oxygen coming in and going down to my lower airways, my alveoli. I've got this vasculature around my alveoli, and we are exchanging gases. So oxygen is coming in, binding to my hemoglobin. The carbon dioxide that was bound to my hemoglobin is now being exchanged out into the vasculature and being breathed out, or ventilated out. So I've got oxygen coming in, I've got carbon dioxide going out. So since we have this flow of oxygen and carbon dioxide, those are going to be the two primary gases that we are worried about and we're paying attention to. I want oxygen going to my cellular tissues, and I want carbon dioxide, this waste product, going to my lungs and being able to be exhaled. With this flow of oxygen and carbon dioxide, we do have to be mindful of our VQ ratio, or our ventilation to perfusion ratio. Ventilation is the V, very obviously. Perfusion is the Q, very obviously. I don't know. Perfusion is Q. Okay, we're just going to roll with that. So VQ, ventilation to perfusion. Here in this presentation, we're going to be worrying about the ventilation portion of this, but VQ is I have enough air moving in and out, and on our Q side or perfusion side, I have enough blood moving around my alveoli so that we get our respiration. We get that gas exchange. So the amount of air that the typical adult, and this is going to be different for everybody, but the typical adult breathes in and out each minute is 4 liters. The typical adult has about 5 liters of blood circulating through the system each minute, so 4 over 5 is 0.8. So a typical VQ ratio for a typical adult is 0.8. Anything above or below that, it's going to be a little bit off, and we'll be worried about either the ventilatory side or the perfusion side. So here we're going to worry about the ventilatory side, not so much the perfusion side. So if we have a pulmonary shunt, or what we're going to call a pulmonary shunt, our VQ ratio is low, less than 0.8. And here we see that our lungs are perfused. So we have good blood flow, but they're not ventilated. So we don't have gas coming in and out. The gas that is coming in and out is being exchanged, so we have good respiration. It is being exchanged properly, but we just don't have enough ventilation. In this, our pulmonary shunt, typical causes of a pulmonary shunt: a low VQ ratio, pneumothorax, whether it be spontaneous, simple, or traumatic or a tension pneumothorax is going to cause a pulmonary shunt, and even more commonly, pulmonary edema is going to cause pulmonary shunt. So our lungs are being perfused just fine. The air that is getting in, respiration is fine, the air is getting in and out, the air that's getting down in there, the gases that are getting down in there, but we just don't have enough ventilation. We just don't have enough gases getting in and out. Now, digging a little bit deeper, we talked about oxygen and carbon dioxide as being our two primary players here in respiration. So we've got air coming in and out, and we've got respiration, the exchange of gas as well. Our hemoglobin, or that Hgb or hemoglobin, are the carriers of oxygen and carbon dioxide. Well, there's a competition here. So oxygen and carbon dioxide both compete for places on hemoglobin. Oxygen and carbon dioxide compete for these hemoglobin spots, and their affinity for those different spots is dependent on the pH in which they reside. So, O2 and CO2 binding to a hemoglobin molecule is dependent on the pH. So let's go back to our acid base and just quickly remember that a high CO2 level creates a low pH environment, and conversely, a low CO2 environment creates a high pH level. So we have to consider these different pH environments. Are they high? Are they low? So we have a couple effects to consider. One is the Bohr effect. The other is the Haldane effect. These two effects really work in concert with each other and keep us well regulated. So first, let's talk about the Bohr effect. It's probably the more commonly known of the two. So with the Bohr effect, when we boil it down, it says that oxygen binds to hemoglobin much better at a higher pH. So where in our body would there be a higher pH? And if we think back to acid base and our carbon dioxide, so a low carbon dioxide would create a higher pH environment. Well, where is there a low carbon dioxide level? Well, it's in our lungs. So in our lungs, oxygen binds better to hemoglobin. Well, that really works out well for us, right? So we breathe in, we ventilate, we breathe in oxygen. Well, in our lungs, there's a much higher pH level, so oxygen is better able to bind to our hemoglobin. On the flip side is the Haldane effect. So instead of oxygen, we've got carbon dioxide, and we're saying that carbon dioxide now binds better to hemoglobin at a lower pH. So remember back to acid base, higher the carbon dioxide level in the system, in the environment, the lower the pH. So where would this happen? Well, it's in our muscle tissues. It's just in our tissues. Carbon dioxide is the waste product. So at this end product here, in our tissues we have a lower pH. So if we balance the pH across our body, we come to that nice 7.4, let's say. But in our lungs we have a higher pH, less carbon dioxide. In our tissues we've got all that waste product waiting there to be offloaded, waiting there to be taken away. So in our tissues we have more carbon dioxide in a lower pH. So here our hemoglobin binds better to carbon dioxide. Both of these are really important because with the Bohr effect, we say that in the lungs, we are more likely to attach oxygen to our hemoglobin and offload CO2. And then the Haldane effect says, down at the muscle tissues where our waste product is, we're more likely to offload oxygen, which our cells need, and attach CO2 to bring it back to the lungs. So they work very well together. So in our lungs, we are unloading, attaching oxygen and offloading CO2. In our tissues, we are unloading, attaching carbon dioxide and offloading oxygen. So in summary, ventilation and respiration, very different from one another. Ventilation is just a mechanical movement of air, of gases in and out. Doesn't mean they're binding or attaching to anything, just an in and out. And respiration is that cellular exchange. So the gases are actually being exchanged, being used. We've got the Bohr effect, we've got the Haldane effect. On the ventilatory side, we've got laminar flow and turbulent flow. So ventilation, mechanical, respiration, cellular exchange. So that's a quick overview of respiration versus ventilation. So if you have any questions, comments, concerns, or even cuss words, please feel free to let us know.